infectious disease specialist at WVU, and I have made it a passion of mine to be an advocate for vaccination. So we're going to talk about the HPV vaccine, and we have a little speaking quiz. Did they already get the quiz?
No, I'm going to go ahead and do that after.
Okay.
I have a few more things I'm going to go over.
Okay.
And before you speak, I'll throw
Okay,
that.
go ahead.
Okay. Mary Ellen, do you want to introduce yourself really quickly, and then I'll go through the rest of the housekeeping stuff?
Hi, everyone. I'm Mary Ellen Kahn. I'm with the WVU Cancer Institute and also with the Mountains of Hope Cancer Coalition. We help to coordinate these ECHO sessions. So thank you for coming today.
And I'll go ahead and share the pre-test. You guys can go ahead and take that while I go through the rest of the housekeeping materials. So go ahead and answer these questions. Can everybody see them? Okay, great. All right, so if you feel comfortable doing so, we encourage you to please turn on your cameras. This will help us to make our session more engaging. In terms of reminders, please mute your microphones during the session. We do want to hear from you, so you can unmute or raise your hand to speak for questions and discussion. The session will be recorded, is being recorded, archived, and excerpts may be used for educational purposes. By participating, you indicate your consent to recording, archiving, and use for educational purposes. So please remember not to disclose any personal information that can identify the patients presented in an ECHO. And finally, the series is approved through the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The WVU Office of CME designates this live activity for a maximum of 1 AMA PRA Category 1 credit. This continuing education activity has been provided by the West Virginia University School of Nursing for 1.2 contact hours. If you did not pre-register, please let us know in the chat if you want CME or nursing credits. Right, so we are recording, so I will go ahead and turn the floor over to Dr. Catherine Moffitt.
Thanks. So they're going to control the slides for me. If you can go ahead and share those.
Yep. One second here. One second, I'll get the right screen going in just a second. There you go.
Okay, so go ahead to the next slide. So here's our first question. How many vaccines currently prevent cancer? Go ahead and hit. So we have two. We have the Hep B vaccine and the HPV vaccine. And of course, there's multiple kinds of cancer that the HPV vaccine prevents. A lot of people don't think about Hep B as being a cancer prevention. Worldwide, it's a huge, big burden of cancer. Thankfully, we don't have much hepatitis B, but a little trivia about Hep B and Hep C. West Virginia is the #1 state, unfortunately, per capita when you equalize it all out with denominator for hepatitis B and hepatitis C infection. So really important, I'm going to plug to vaccinate for Hep B. Next. Okay, so the burden is huge. And for everyone, male and female, in their lifetime, it's expected that nearly all of us will get at least one mucosal HPV. Now, I'm not talking about HPV that causes warts on your hands and feet. I'm talking about mucosal, meaning genital or oral genital. And this is felt to be, I think it's greater than 85%. That's what you see in the literature. Some people feel it's closer to even 100%. Even nuns in France who were monogamous have had evidence they have HPV infection. Next slide. And I think the point is, you may have seen the last bullet there, most people don't know they've ever had infection. The only ones that give you a wart, now we're not talking about the green ones, because the green ones are the hand and foot warts. We're talking about the ones in blue, the genital warts. HPV 6 and 11, those cause warts, and you see them. It's these in orange that you do not see anything. And the only way you can detect them is by biopsy, which we don't usually do, although you can biopsy and stain to find HPV. It's by PCR swabbing, or a surrogate marker for HPV infection is the pap smear. And we're going to talk about that a little bit later. Go to the next slide. So here's all the ways that you can transmit HPV. You know, it's oral, oral, genital, 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 hand, genital, genital, hand, and vertical, meaning at the birth of the child, they acquire HPV. And the ones they usually acquire are the 6 and 11, the warts. And then they go to laryngeal papillomas, meaning they get papules or growths on their larynx, their voice box, and can be a very devastating, very challenging to treat these babies. Next slide. So I looked for the most up-to-date on prevalence and, you know, of HPV, and this one, and actually I'm going to get down close and read. So this is cervical cancer worldwide, and this is 2023. So the darkest blue is where the burden of disease is. You can see in Africa, in Indonesia, in Asia, Russia, Mongolia, South America, even Central America. And why are we in light blue? We certainly have cervical cancer in US, Canada, Europe, Australia, but we screen for it. And the other places in the world have no means to screen for it, no means to diagnose it, and absolutely no means to treat it. Next slide. Now, here's the WHO HPV immunization programs. So we've made some headway in South America. We've made some headway in some of Africa where there is consistent vaccination. But you can see, remember, if you superimpose the maps, where there's the worst disease of cervical cancer and death is in parts of the world where there's not good, consistent, or maybe no vaccination. Next slide. So I like this kind of the whole idea of the tip of the iceberg, and these circles are meant to be the you know, relative to each other, how many cases. We all have heard of and we know about cervical cancer. It is something that people do talk about, although I think there is a stigma of having a genital cancer, but it is something people talk about. The precancers are more than 10-fold higher than cervical cancer, and hopefully you detect them, you find them, you prevent going to cervical cancer. Look at the circle below, is bigger than the amount. Did you know that there is more cancer of the head and neck annually? These are annual cases than cervical cancer. And then you can see all the others below it are cancers that are genital cancers of words that people don't even like to say. And so when you go to a, you know, when you're talking to someone, you may say, oh, I know someone who was diagnosed with head and neck cancer. Oh, you might not say, oh, my mother was diagnosed with cervical cancer. The implication may be there. Maybe we do talk about that. Nobody talks about genital warts. You don't go to a cocktail party and say, oh, guess what my 20-year-old was just diagnosed with? She has a bad case of genital warts. No one talks about that. So the burden, even though 6 and 11 don't cause cancer, usually, there are some exceptions. Those babies who get the laryngeal papillomas, there have been cases of lung cancer associated with either HPV 6 or 11. But this gives you an idea of the annual burden of the disease. Next slide. So why do we need to vaccinate as a prevention vaccine? So the most important take home today, if you can get from this slide, is the age at which a female starts their first sexual intercourse. So if they're less than 17 or less, those are in red, or not 18 to 22, and it's probably lower if you're older in blue. The likelihood of this woman in her lifetime having an abnormal pap smear, that's the CIN, or invasive cervical cancer is 5 times or more higher than if she just waits to become sexually active. And you may answer, why is that? Well, the cervix is immature. It doesn't have as good a mucosal barrier. It's more wide open. So it's susceptible to HPV infection. It's been shown that women are more likely to have an older male sexual partner when they are in their teens than a male having a young they're in their first sexual encounter. So women are going to, the likelihood then of being exposed to HPV at age less than 17 is high. We're exposed at any age, but our defenses are less good in our cervical area when you're younger. So you can say to people, well, tell your daughter and your son not to have intercourse until they're an adult, but we won't vaccinate against HPV. See how that works? I mean, we've been saying that, and that's actually good things to say. And I don't mean to make fun of that. I mean to say those are good conversations to continue to have. But at the same time, let's prevent HPV. Because how do you know that isn't a woman who has had a date rape, who has made a mistake and really regrets it, and now she has HPV at age 15, and her risk now of cervical cancer is 5-fold higher than someone who didn't make a mistake or didn't have a scenario. So really, really important to understand that the age for women for HPV risk is high, although we have that risk at any time in our life with HPV. So next slide. And so here are the rates of oropharyngeal cancer. People don't think about HPV causing head and neck cancers. We're in red, which is the worst. You can see the states that are red and then the states that are in blue. Now, I looked for a more recent map. This is 2013 to 2017. I could not find one. There's data that exists, but I think the map is a very visual thing. I don't think this has changed in 6 years since 2017. If anything, it may be a little worse. Next slide. And here's West Virginia. So you can see the counties, and some of the counties are not counted because there's too few to count. And the feeling is that potentially a person looks at this and they live in, well, I don't know, maybe I don't know what county's on here that's in shaded. Sorry, I don't know my counties now off the on demand well enough, but it could identify a patient. So there has to be a big enough number to put on the map. The thing about oral cancer from HPV is there is a lag. This is a cancer that's diagnosed when you're 40 to 50. So we may not see an impact. We may now, well, not yet, see an impact of our vaccination of young people because the vaccine was licensed in 2006, but it was for females and more men, although women do get oral pharyngeal cancers from HPV, but it's more men. And so we're not going to see an impact. When is our cohort of vaccinated young people going to be 40 to 50? It's going to be another 10, 20, 30 years from now, which is why these rates continue to go up when we are seeing a slight decline in cervical cancer rates. Next slide. And so here's the death rate for oropharyngeal cancer. And again, there we are in West Virginia, we're in red. Next slide. This is interesting. This is data 2022. It's data from West Virginia for 15 to 19. There's no more recent data like this, but it shows that if cases are falling, they're going to the left, they're in blue, or if they're rising to the right. And you can see cervical cancer has shown a slight decline, yay, and oral cavity pharynx is increasing. And for the reason that I mentioned, that it's the population it's being diagnosed in, and they have never been vaccinated because it didn't exist when they were younger. Next slide. So I think this is just so telling to me. I ask my patients, if you had a vaccine for cancer, would you use it? What about breast cancer? What about lung cancer? What about prostate cancer? What about you name the cancer and you insert it? And I think everyone would say yes. So why is it that there's such a stigma about HPV vaccine? I think it got launched as genital, cervical, genital warts, girls only. And then the boys, it was the permissive, but not recommended. Now it's recommended, but now the vaccine's up to 45 for women, but only 26 for men, and then only if they're high risk. What kind of message does that send people? Well, I'm not in that category. My son's not in that category, whatever. It should have been cancer. And if you say HPV, this is a cancer vaccine, and that's all you need to say. But I'm going to give you some tools. Go ahead, next slide. So look at this. In 1959, these were lines for polio. Now, polio didn't cause cancer, but polio caused horrible disease. And in 1959, there were 8,425 polio cases reported. Now, there may have been more than that, but remember the number of cases of cervical cancer is 3,000 or 4,000 more, head and neck, all the cancers is way more than that. And yet, why was there such a demand then? And there aren't people lining up to get their kids or themselves vaccinated. I have a hard time. Next slide. So here are the vaccines that have been available, the HPV-4, and I am going to call it Gardasil because I think we know it as Gardasil. And then the bivalent HPV-2, which was known as Cervarix. So HPV-4 had 6, 11, 16, and 18. And then the Cervarix only had the 2 oncogenic or cancer-causing 16 and 18. Gardasil kind of won out in the battle. So just hit it once. And hit it again. And so now the only vaccine left is the HPV-9, now known as Gardasil 9. So it contains the original 4 plus 5 more oncogenic or cancer-causing strains. Go ahead and hit it again. And again. And so Cervarix is not available in the United States. I have heard that it is available in other parts of the world. And my feeling on that is, if that's the vaccine that you have and you can prevent the 2 strains that cause by far the majority of disease of cancer, then use it if you don't have access to Gardasil 9. But the standard really is the HPV-9 vaccine. Next slide. So here just shows the bivalent, the quadrivalent, and now the 9 serotypes. And you can see that we added, by adding those 5, you've added 6% more of the oropharyngeal. And really for cervical cancer, we're getting somewhere between 90 to 95, 98. I don't know. Don't quote me on that number. We're not getting all of the strains of cervical cancer, but we're certainly getting the majority. Next slide. All right, so go ahead, hit it again. This would be my sons when they were in college. They want to make ravioli. They don't have a colander, so you use what you have at hand. Next slide. No, what you really need, you need the right tools. So we're going to talk about the tools to talk about and the knowledge behind what are some of the myths, and be prepared when you are talking about vaccination and why we need to vaccinate. Next slide. All right, top 10 list. Next slide. Number 1, the vaccine is safe. So I looked up, this is as close as I could find. It's probably more than this. Over 400 million doses of the HPV vaccine, of which the majority of those are HPV-9, have been distributed, and 135 million in the United States. So there's multiple safety articles, peer-reviewed, published. No serious safety concerns have been identified. So an adolescent comes to be vaccinated. The next week, they're diagnosed with lupus. True, unrelated. You come and you get vaccinated today and you're in a car accident tonight. I hope that's not the case. You're in a car accident, you were vaccinated. True, unrelated. So many of these concerns about autoimmune disease, about suicide, about depression, all of those have been very carefully studied and showed that there's no relationship with the HPV vaccine. You happen to be the age and the demographic when those things are happening, not a concern. Next slide. So we have multiple layers for vaccine safety. The FDA at the bottom requires post-licensure immunization safety monitoring by the pharmaceutical company. That's not voluntary on they have to follow to make sure the vaccine they have is safe. Then you look at a more industry with CDC and 7 academic centers who are looking at vaccinations and safety assessments and its clinical research. Then we have the passive program called Vaccine Safety Data Link, and many of you may be familiar with this. You can go online and fill out an adverse event. Someone got a severe local reaction. They had high fever after they had Guillain-Barré, they had a seizure, whatever they had. I'm not saying that it's caused by the vaccine, but you can report this. This is a passive reporting, meaning it's not, no one is demanding you to report, you voluntarily report, but we as providers will do that very frequently. It is a way to get a signal that there may be a concern. It also is used by many anti-vaccine people, that lawyers, anyone can put things on the Vaccine Safety Data Link. And then they look at this big database and they say, we're covering it up, or look at all the things that have been reported. Well, they haven't been proven that they're the cause, they've just been reported. So the really important is the Vaccine Adverse Event Reporting System known as VAERS. This is prospective, meaning it started from today moving forward, and it's using the data we have in these electronic medical records where you get vaccinated today. It hits a switch somewhere, and then they watch to see, you're anonymous. They can't contact you, but to see, oh, in 3 days you were in the ER. Day 4, you were admitted and you had whatever. Is that vaccine related or not? Or a month later, you were in the ER and you were admitted, or 3 months later. And are any of those related? And they look, so one of the things that actually was reported by the Vaccine Safety Data Link was the cases of intussusception following the very first rotavirus vaccine. And after about the 9th or 10th child who was reported, then they looked and then actually pulled that first rotavirus vaccine. Now we have 2 that were studied more with greater number of patients, and the signal is not there that those vaccines are associated with intussusception. Next slide. So we have now over 18 years of HPV safety data. And yes, you can get pain, redness, swelling on the arm, maybe some fever and headaches, but they're not, the safety is there. Now, who should not receive a vaccine? Well, if you have an allergic reaction to the vaccine, yes, or to yeast, then you should not receive the vaccine. Pregnant women, there is a registry following women who have been pregnant and inadvertently gotten an HPV vaccine. It's not recommended that you get it. It's not a live vaccine. And there have been no adverse events of fetal problems or babies born, but it's just one that is not recommended you get when you're pregnant. With any vaccine, adolescents faint. It's felt that maybe boys faint, syncope a little more than girls. And so being safe, watching them, if somebody has fainted before, they should be seated or lay down 15 minutes and watch them. Next slide. Doesn't cause serious side effects. So we continue to be monitored for safety. Next. And it doesn't make a child more likely to be sexually active. These are awkward conversations, but knowing the facts, and a parent says, well, my child is not sexually active, good, continue to have those conversations. This is a prevention vaccine, not associated with autism. They've looked at 14-year-olds. This is older data because we recommend vaccinating before 14, but if you haven't been vaccinated, get it at 14. 14-year-olds who went for primary care visits, the ones who got vaccinated, the ones who didn't, and there were no more pregnancies in the vaccinated group. There were no more STIs in the vaccinated group than the unvaccinated group. So it doesn't give liberty to go out and be wild and crazy. Go ahead and hit it again. So this is the myth busters. These do not happen. Next. So why are there so many teens who have not received? Well, this is interesting. This is a little bit old data, but I don't think it's all that different today. Look at the number one in both male and female, not needed, not necessary. A little more concern about safety for girls. For the boys, not recommended, lack of knowledge, not sexually active, safety. And the girls, it's the fourth one down, not recommended. Well, it should be recommended, and it should be recommended for both. Next slide. There's no effect on fertility. And there are countries around the world that have been worried and voiced concern, not more than worried, that we as a first world are trying to sterilize, especially their daughters, by vaccinating against HPV. But I've also heard that argument with polio. And so what you need, if you're doing any global health, is to have the local people help you to deliver vaccines and get the support of the elders in a community, the religious leaders, and have them understand that we're not trying to sterilize anybody with vaccination. Next slide. There's actually, great evidence that women who undergo cone or LEEP procedures, colposcopy, are more likely to have preterm labor, preterm rupture membranes, low birth weight, or perhaps cannot even get pregnant or stay pregnant. And certainly a woman who has cervical cancer who needs total surgery will not ever have carry a pregnancy. So my argument is that by vaccinating, you're actually preserving fertility. Next slide. No harmful ingredients. The amount of thimerosal and aluminum that are in vaccines are equivalent to the amount in one serving of breast milk, infant formula, antacids, fruits, and vegetables. So thimerosal and aluminum have been unfairly targeted, but these are natural ingredients, and they are contained in this vaccine because they serve as a preservative and as an adjuvant to help you really respond to the vaccine. Next slide. So anybody can receive the vaccine if you're 9 years of age and older. The cap is 45 for women, 26 for men, unless you're high risk. But we are now in the age when we are in such a box about when you can use vaccines. But I'll give you an example. What about a woman, a man, but a woman who's been monogamous, had one sexual partner, her husband dies or gets divorced, or whatever the scenario, now she's out in the dating world and she's 46. She's at high risk for acquiring HPV. Absolutely vaccinate her. What is the risk of vaccinating? Well, it might not be paid by insurance, although they may not pay attention to the age, so that might not be a big deal. The response may not be as brisk, but in a healthy person, it will be good. So I think that we do a lot of things that are off-label. And so I can say this, I don't care for adults. but if I did, but I've talked to many adults about whether I would recommend or advise them to get the vaccine, and the answer is yes. Now, I didn't point out, but in the earlier slides when it showed the vaccine that is available, if you get vaccination schedule is 2 doses if you're under 14, and if you're older, it's a 3-dose series. So if you're 10, you get 1 today and 1 in 6 months. If you're 20, you get 1 today, 1 in 2 to 3 months, the third one in 6 months. If you've missed your dose, you don't repeat the first one, you get the second one, and then the third one. Or if you're still under, if you're younger, it's been more than 6 months, you just get your second one when you get it. Go ahead, next slide. So preteens, this is well established, and even I should highlight 9 and 10-year-olds, you get an incredible immune response the younger you are. Not to say that you don't get a good immune response when you're older, because you do, but there is no evidence that you need to be revaccinated right now. And I look to see what anyone has written, and there's nothing lately, but the feeling is that the immunity, the evidence so far has been, you check somebody 10, 12 years out. Now, we cannot do a titer, so we cannot clinically do that. But the research has shown you check a titer, you look at protection of women in terms of diagnosing cervical cancer, the protection is still there. Next slide. So go ahead, one bullet. Why do we have to give it at a young age? Well, look at this. This is age of first sexual intercourse, and this data is old. So I haven't found one that looks quite like this in later, but maybe the bars are a little down, maybe they're a little higher. I don't know. I don't know what 7% of 12 and 13-year-olds are doing, but that's way too young. Even 14 to 15-year-olds, 1/3, nearly 1/3 of 14 to 15-year-olds have already been sexually active. So this vaccine needs to be given before any of this. And so the recommendation initially was 11 to 12. You could give it to 9 or 10-year-olds if they were high risk, if they had already had sexual assault. Now the recommendation is just go ahead and think about giving it at 9 and 10 and get it before, just give it. Go ahead. Next slide. So it's prevention. So information early on, the HPV vaccine is for both males and females. Remember the slide that said it wasn't recommended? It should be recommended for everyone. It doesn't matter what your gender is. And it's more than cervical cancer. It's about genital warts and it's about cancer. Next slide. This is hard to read, but I just want you to look at the very bottom 3 lines: total, male, and female. So the average number of cases per year where HPV is found, and then percent probably caused by HPV of cancer, and then estimated number of people. And so if you look at the total, 37,000 people with cancer and a little more female than male. The females are catching up with the oropharyngeal, but that number is going up. So it's a burden of cancer. Next slide. And we don't have similar slides to even say the burden of warts, because that's not data that's collected, but it's very high. So HPV, when it was when the 2 vaccines were licensed in 2006, and then when we went even to the HPV 9, the vaccines were not studied to prevent cancer. So Merck, who's the company that makes HPV 9, cannot market this as a cancer prevention, but the public health and all the rest of us can talk about it, because when they did their studies, they were just showing that we were decreasing the acquisition of HPV, either on the cervix or with male scraping of genital parts or at the rectum. Now there's clear evidence that we are preventing cancer. Next slide. So still estimated 1 case is diagnosed every 20 minutes. Next slide. The impact on oral infections, it's that only 18% of the US population has had 1 dose, but the prevalence still has been reduced, but we're not going to really reduce oral pharyngeal cancer until we really vaccinate more of the population. Next slide. So it's associated with a reduction, but it's the low vaccine uptake is going to be modest overall. Next slide. So how long I looked, this is from 2016. I looked at ACIP. I looked to see if anybody has said more than 10 years, because that's 7 years ago. And I think just the consensus is, yep, still have protection 17 years later or 20 years. Some of the women who were in the original studies are from the early 2000s. The Scandinavian countries have what's called the Nordic study, where they're socialized medicine, so they can access all records. And women who were vaccinated have been prospectively followed, and the women have not developed cancer. Or when you diagnose cancer, now we can do these swabs and these probes to prove which HPV strain it is. And it's an HPV strain that's not protected in the vaccine. So remember, there are HPV that can still cause cancer, low numbers. So that's very powerful information that in Scandinavia for 20 years or plus, that the women vaccinated, the amount of cancer has gone down. Next slide. So we've already said the HPV vaccine is safe. And so when you're talking to pre-adolescents, adolescents who are at the platform to get their quadrivalent meningitis vaccine, known as meningococcal ACWY, and the Tdap, the tetanus, diphtheria, acellular pertussis vaccine, the safety is similar. Go ahead and hit again. And it's effective, that we're showing prevention of warts and of cancer. Next slide. And that the protection lasts. So not a reason to wait, not a reason to wait until they're sexually active, not a reason to wait. You have even a prepubertal child who's 9 or 10, good, let's give you a vaccine that's going to prevent cancer later on in life, and then have good conversations about good choices, and then move on. Next slide. Many people don't even know about the HPV vaccine. I'm amazed. 1/3 of parents had no prior knowledge. And if they've heard anything, they've heard not accurate things, but they don't realize that there's a vaccine that prevents cancer. Next slide. So I like to say that human papillomavirus is the common cold of the genital area. It is not seen, but it is common, and it's spread and facilitated very easily, human to human. Next slide. So I used to ask 3 questions, hit it once. Again, now I ask 5 questions. So my first question, go ahead, is, do you know someone who's had an abnormal pap smear? Now this is to say, you've had the conversation already. Yeah, Johnny needs to get 3 vaccines, and I like to sandwich. They need the meningitis vaccine, the cancer prevention HPV vaccine, the Tdap. Okay, fine. Well, then they question a little more. Well, what about that? So now you're talking about, why is it important to get the HPV vaccine? So here's one question. I think most people know someone who's had an abnormal pap smear. Next. Do you know someone who's had colposcopy? Maybe they have, maybe they never heard that word before. Next. Do you know someone who's had cervical cancer? So I think that most people know a woman who's had one of these. And then you say, well, if this woman could turn back the time, these are all caused by HPV. And if she could have been vaccinated when she was young, she maybe could have prevented all of this. Next one. Do you know someone, and I'm putting in parentheses, with HPV-related cancer of the head and neck? Now, smoking, tobacco, cigars are related to cancer. Those cancers have really plummeted. They still exist, but the HPV-related cancers have gone up. And it has to do with many things. It's not like HPV all of a sudden appeared and we didn't have HPV before, but I think the sexual practices and the more liberation of sexual partners has really changed in my lifetime. If you look at what was then happening in the 60s, 70s, 80s, and really we are looking at men who are 40 or 45 now, or 50. So 40 years ago, believe it or not, was 1980s. 50 years ago was 1970s. So these are men who were adolescents, young adults acquiring HPV then, probably now they have their cancer. So we are seeing them go up. And then the last question is, do you recommend pap smears? Because what are we trying to find on pap smears? We're trying to find abnormal paps, hopefully not cervical cancer, but we're trying to find cervical cancer. Now we have these probes to look for high-risk HPV. If you don't believe in pap smears, well, then you don't believe in vaccination. If you don't believe in vaccination, then why are you believing in pap smears? They really should go hand in hand. This is about finding the cancer. We want to turn it back and say, let's prevent it. But the recommendations still hold for the frequency and when you need to get pap smears. So remember, not all cancer is prevented in the vaccine. Women still need pap smears. So if you can answer yes to one or more of these questions, then you should be vaccinating against HPV. And I think helping families say, oh yeah, the mother, yes, I get annual or every other year pap smears. Okay, they're looking for cervical cancer. What if they find cervical cancer in you? Would you want your daughter vaccinated now so she doesn't have, you can think of the scenarios you could say. Next slide. All right, who is this? He's married to Catherine Zeta-Jones, a very beautiful woman. He's a little older now. This is Michael Douglas, HPV 16, head and neck cancer, in remission. Next slide. Who is this? My hometown. I grew up outside of Buffalo. This is Jim Kelly, had recurrence of his head and neck cancer, still a survivor. Next. Who's this beautiful woman? It shows your age if you know who it is. She's one of the original Charlie's Angels, not one of the new ones. This is Farrah Fawcett. Farrah Fawcett died of rectal anal cancer from HPV 16. She has a foundation. You can Google her. You just put in HPV Farrah Fawcett or HPV cancer or Farrah Fawcett cancer, all about getting the word out about vaccination and prevention of HPV disease. There was going to be a big launch of all this information on the day she died. She did these videos when she was getting chemo and very heartwarming, and really was her passion to get the word out. She was too old to have benefited from receiving a vaccine when she was younger. And then somebody else died a day before or a day after she died and totally eclipsed the news, and that was Michael Jackson. So we didn't hear all about Farrah Fawcett and HPV because then Michael Jackson died. Next slide. Go ahead, one. Who's this? He's young here. This is Val Kilmer. Next slide. This is Val Kilmer today. He looks a whole lot different. And if you saw the Top Gun Maverick movie, he's in the movie, and you notice he's wearing a scarf. So he has HPV 16. He has had his voice box removed. He has a trach, and he does have a way to speak. But in the movie, that was not his voice because they didn't want to use his voice. because it didn't sound the same as what they had in the movie. But HPV 16. And he's really been ill. It's really profoundly affected his life in a very negative way. Next slide. So parents do want their kids to be vaccinated. And when the surveys, go ahead, the next slide. Here's what the parent in the dark blue and the providers estimate, the estimate of what providers think. And the parents want their kids vaccinated. Look at HPV. 9 out of 10, whereas the provider thinks the parents only half the time the parent wants to be vaccinated. So against meningitis, against hepatitis, pertussis, flu, HPV, parents want their kids protected when they understand the facts and what it's doing. Next slide. So recommending just takes less than a minute. Your office should be all on board. Checking in at the front desk. Oh, my kid's going to get vaccinations. What do you think? And your clerk says, I don't know. Okay, that isn't good. They're getting weighed and measured, and they're saying, what vaccines are we getting today? And they say, oh, they need their meningitis and their Tdap. No mention of HPV. Your office staff should all be on board. At pre-adolescent, you're getting 3 vaccines. What 3? Sandwich HPV in the middle. Don't call it genital, don't call it sex, don't call it wart, call it cancer prevention. And then you can elaborate more if there's questions. Tdap, HPV, cancer prevention, meningitis. Meningitis, HPV, Tdap. Put it in the middle, sandwich it in the middle. And then if you are asked questions, you are prepared to say, what are you worried about? The safety is the same as all the rest of the vaccines. It's been studied. There have been over 400 million doses given worldwide, 135 million given in the United States. Safety. Oh, my nephew was diagnosed with autism after he got his measles shot. Well, there's no association with autism with measles. There's no association with the HPV vaccine with autism or lupus or anything else. Next slide. So 2 sentences. Next slide. You need 3 vaccines, whooping cough, HPV, cancers, meningitis. Next slide. And you'll get those today. And most people are like, okay, next slide. So I ask you this question. Next slide. Why are you waiting? Why not vaccinate? So I'll take any questions anyone has. And then we have the post-test, the same questions that we had at the beginning.
Thank you, Dr. Moffitt. I'll go ahead and share that post-test. And yeah, we did not have an official case submitted. So anybody who has any questions for Dr. Moffitt, you can ask her. And if you have a quote unquote case, an example of a patient that you see or, sometimes see, you can please feel free to ask her those questions.
So I think maybe I didn't really emphasize, but in the post-test, the one question is so people come up with the concern, they're already sexually active. No, they don't need to be vaccinated. Yes, they do, because you may have only acquired 1 or 2 strains, but we could prevent 7 others. You've already been diagnosed with an HPV infection. Doesn't matter, still is a benefit to vaccinate to prevent the other strains. So the only absolute contraindications to the vaccine are hypersensitivity to yeast and to the vaccine, and the one of not being pregnant is a contraindication. But if the teen is pregnant when you give it, you can go online and report that to Merck. But the studies have shown there have been no reported adverse.
Dr. Moffitt, we did have one question. Somebody
Yes.
had, are you finding more parents do not want vaccines these days, not just HPV?
Yes, unfortunately, a little bit. And what happened during COVID is that the really young kids weren't coming for primary care visits and hence didn't get vaccinated. And then that catch up has been really challenging. Now they're not in the age to get HPV, but yeah, there's the growing sentiment. I think that this is my take on it. I think if we look at the whole extremes of, we can make other analogies to other things, but there are the people who are absolutely no, you cannot convince me. Then there are the people who are like, absolutely, don't even have to tell me about it, I'm going to vaccinate. And then you have the margins and the, yep, I'll be vaccinated, let me talk to you about it. Then there's the ones down here who are, I'm not so sure, I have this concern, you talk about it. If somebody brings up a concern and I don't know the answer to it, I will say, I will find out and let you know. I don't just blow them off. That shows the confidence then if you don't listen and you don't take the time to answer the questions. So I do wonder if what we hear about anti-vaccine is still more vocal people, but of the extreme, or have more people now moved into that side of absolutely not. I have real concerns this year in our legislative session that we're going to lose the vaccine battle, and we have been so strong in West Virginia that only for school is there a medical exemption. So that greatly worries me, because there are no organized religions that have a mandate about not vaccinating. Even the Pope says that there have been vaccines that in the original design, not currently, but in the original design, fetal stem cells were used. The Pope says, we're talking about the health of babies and pregnant women. And if we can prevent disease or bad outcomes or death, then we choose vaccination until there's a better alternative. So I think that it's a challenge. We're in a challenging time now. We definitely are.
So I have a question. Do you as a provider, when a child comes in, say at 11, 12, is supposed to get those 3 shots, do you feel like that there might be some advantage to recommending, the HPV at 9 and then having 2 later at 11, 12? Or does it matter that there are 3 shots at that one visit?
Well, I'm not worried about 3 shots. I'm not worried about 4 shots. I know that kids complain, and I joke with them, and I'm like, oh, why are we giving you? We're torturing you. No, we're not. We're making you sick. No, we're not. We're trying to help you. I mean, I kind of joke and sympathize, but you're right. There's a burden. I think know your families. If you see a 9-year-old and they're in a really high risk situation, and mom was pregnant by the time she was 11, or this girl or boy, or especially the girls I worry about. I'm not sending a double message, but I think I look at the girls and they're already having their period, I would vaccinate them. So separate that. And then the other 2 are mandated by school. So they're going to have to get those other 2. But the HPV, if you can give it earlier, because one of the Tdaps is 10, the other one is 11. So, we can't give that at 9 unless we have a reason that they haven't been vaccinated fully before then or whatever. So yeah, I think it's know your families. But if you say, we could get this one, and then you have to come back for your second one, but get this one out of the way. So then when you get your ones for 7th grade, you're only getting 2 at that visit. That's a way. I think you have to know your families and approach it and discuss it with them. Let them have a little input into it. But if you can start at age 9, go ahead and do it.
Dr. Moffat, I have a question, and it's related to, say, a parent brings a child in and they start the series, but
Yeah.
they don't come, they don't follow through with
Yeah.
having the second. What type of suggestions do you have of, how to communicate with the caregiver.
Well, I have two answers to that. One of which, there actually is evidence, and they're really looking at this to say, could we just give one dose? And the younger you are, probably your response is so much greater. So it may be that we may only be giving one dose, but that's not the recommendation now. So I wouldn't say that to a parent, because then they'll be like, okay, we're not getting any more. I would say, because we definitely know that that second or third, the one that's the furthest point out, really gives you a boost to, same with like Hep A. You know, why we give 2 doses of Hep A is to really give a boost to then maintain immunity. So I think that the older patients, there is probably going to be a recommendation of more doses. And if there is a 1 dose, it may be only for the younger ones, but that's not here yet. So I think it's really emphasizing to them, really important. You know, you already got this started. Let's finish what we started. Let's really protect your kid. And you don't have to start it over. So they don't have to get, you know, they don't have to start at 0. You already got the first, you know, at dose 0, time 0, 6 months. It's more than 6 months, you give the second.
Thank you, Dr. Moffitt, and thank you everyone for your questions. Yeah, Susan, go ahead.
I just have one more question.
Yeah.
What do you think about providers who, I know it's not as common, but when my children were of the age of getting HPV vaccine, my provider was not recommending it. I spoke to the provider and said, I want this for my child. Yeah. And there's still some providers around West Virginia who are not recommending it. Is there, I mean, other than your wonderful slide presentation that really convinces them?
I really have been arguing with, and there's one provider who still doesn't really recommend it for males. And I think, you know what, how are you going to feel if you in 25 years, you learn that this young man has throat cancer? Or how are you going to, you know, these are not diseases that as pediatricians we deal with at all. Even the cervical stuff, we don't see that. We might see some warts, but we don't, you know, and a lot of pediatricians are like, send the sex stuff to somebody else, you know, and then not even many pediatricians don't do pap smears and things. But so I think that I think it's unconscionable. And I really wish, I think there needs to be more data out there. Certainly, I think other providers who care for adults maybe really see the burden of HPV disease and then understand it's important to vaccinate when they're young. But no, I agree with you. I think it's really challenging. There's an OBGYN in town who is so passionate about this vaccine. And she's like, hey, if a woman wants to be vaccinated, I don't care what their age, you send them to me, I will vaccinate them. Because I think it's just the, you know, all right, something that I think is funny, but then you kind of go, I don't really want to hear that. There are outbreaks of HPV genital warts in retirement communities in Florida. You know, I kind of do one of these and then I think, well, I'm almost of the age where I might be living in one someday. But you think about that and you think there are people who are widow or widows or divorced or whatever. And there's a lot of sexual activity going on. And you think, wow, you know, you're not talking to grandma at Thanksgiving over the fact that she now, or grandpa, that he has genital warts. And you think about that and you go, wow, that's something that's preventable. Now, will those older folks develop HPV related cancers? There's not data on that, and probably not. I don't know. I think the head and neck probably not, because it takes several decades before you develop. And I don't know what the condition is then of your cervix to developing cervical cancer if you acquire HPV 16 when you're 75. I mean, that data doesn't exist, but the wart data is definitely there. And so you go, interesting. Wow. Yeah, too much information maybe, but the reality is that it's a virus of all ages and all people.
Thank you.
So thank you. These were all really good questions.
Yeah, thank you, Dr. Moffat. We really appreciate you taking the time, and thank you all for attending and listening. This was our final Cancer Echo session for the 2023 year. We'll be picking it back up in January 2024. So keep an eye out for that. It'll be on a new system. It's still Echo system, but they've created iEcho. So you'll now have calendar invites come out from that system and things. So just keep an eye out for that. And thank you all again.
Thank you.
Bye, everyone.
Thank you very much.
Thank you.